on land which has long served as a site of meeting and exchange amongst Indigenous peoples. We acknowledge and thanks the diverse Indigenous peoples whose presence marks this territory on which we now gather. Just a reminder to please leave your questions till the end of the presentation. We ask that you enter them in the chat, and please answer a brief survey that will be sent to you immediately after the presentation. It will let us know that you were present today. And finally, welcome to Medical Grand Rounds. Our speaker today is courtesy of the Division of Endocrinology, and I would like to ask the Chief of Endocrinology, Dr. George Fantis, to please introduce our speaker.
Thank you, Nadia, and welcome to everyone who's in the room at Medical Grand Rounds and to all of those of you on Zoom. So it's a great pleasure for me today to introduce our speaker, Dr. Meredith Hawkins, who's a Canadian and currently professor of medicine in the Division of Endocrinology at Albert Einstein Medical College of Medicine in New York. She holds the Harold and Muriel Block Chair in Medicine and serves as Associate Director of what's now the New York, she just told me, the New York Diabetes Research Center that incorporates almost all the institutions in New York in the area of diabetes. She's also founder and director of the Global Diabetes Institute at Albert Einstein. Dr. Hawkins completed her MD and clinical training in medicine at the University of Toronto, and then went on to Albert Einstein to do a postdoc, and of course never came back. So she's been at Albert Einstein since then. She was funded by the CIHR at that time and the Juvenile Diabetes Research Foundation, and then recruited as faculty, of course, at Albert Einstein. Her early work focused on insulin resistance and hepatic glucose production and regulation in type 2 diabetes and obesity. She worked on adipose tissue and the role of inflammation, as well as the hormones adiponectin and leptin. And more recently, her studies involved metabolomics and human subjects, and she followed up on what she'll show you today, a remarkable form of diabetes that's been developed, and she's become a global leader in this area of what's now called type 5 diabetes. She first investigated in about 3 years ago. Of course, she's been recognized by numerous awards for her work. The Outstanding Investigator Award from the American Federation of Clinical Research, the Novartis Young Investigator Award in Diabetes, and induction into the very prestigious American Society for Clinical Investigation. And she serves currently on the NIH Steering Committee on the Heterogeneity of Diabetes. She's also, besides her research accomplishments, she's an excellent educator and has been inducted into the Davidoff Society for Outstanding Medical Education and received an Outstanding Mentor Award from Albert Einstein Department of Medicine. So I can go on. She's, of course, on many review committees and journal committees, but I'll stop here and allow her to give her talk on type 5 diabetes. So welcome, Meredith, and it's a pleasure to have you here.
Thank you, Dr. Fantis, for that kind introduction. And I want to begin by telling you why I'm particularly delighted to be here with you today at McGill, because over the various years that I've been in New York, there's always one question that comes up. As soon as anyone has heard that I'm from Canada, the next question that comes is, did you go to McGill? So I always have to say, no, I didn't. I have to explain that I went to University of Toronto. That usually takes a little explaining because they don't always know that there is a university in Toronto. But anyway, we get past that one. And but ultimately, I'm obligated to say, but you know, that my best professors at the University of Toronto came from McGill, like Herbert Hoppincong, the iconic internist, and of course, Dr. George Fantis, the iconic endocrinologist. So it was a pleasure to know that he's now back here and that he would invite me to talk about a topic that about a story that's not new, but about a name that's brand new. And so it gives me great pleasure having worked on this for a while, that finally we have a classification. I can finally give you a talk about something that a lot of people have not yet heard of, but we hope very soon that they will. And I would also have to say that it gave me enormous pleasure over the last couple of weeks to tell my colleagues, and I'm going to be lecturing at McGill. So it's like, finally, she's going to be at some Canadian medical school that they've heard of. So this is terrific. Thank you for the honor of being here. So we are indeed trying to crack an enigma, and I'm going to show you how, in fact, how did it get the name, and how are we attempting to crack this enigma? So first of all, you've probably all seen this whole map before, put out by the International Diabetes Federation, but it's noteworthy for a couple of reasons. I'm going to move my little cursor around here to show you the world numbers. And we know that diabetes is major league increasing. Of course, some of you may know that a recent paper in the Lancet suggests that these numbers are a vast underestimation of what's really happening. Lancet paper recently suggested that we already have over 800 million people with diabetes in the world. The problem being that we're not stopping there. The problem is that this is all still steadily increasing. And we think about other very important and devastating diseases in the world. If you think about HIV/AIDS, with a prevalence, from what I understand, still holding at a plateau of about 30 to 35 million, very challenging disease. But I'd like to point out that diabetes is also extremely challenging, particularly when we're looking at low and middle income countries where the infrastructure is not as adequate to deal with the complexities of this disease. And I'd like to point out that among the new cases of diabetes that are occurring right now, at least 80% of them are actually in low and middle income countries. So what does that look like? In many cases, it's in the urban slums where these people are getting type 2 diabetes, and we've got some experts in gestational diabetes and diabetes in pregnancy to be able to tell you that, of course, that early life undernutrition, when they then get displaced into an urban slum, and the bad food is cheap, as it tends to be everywhere, and they can put on some weight, they can easily get type 2. And that's a phenomenon, Barker hypothesis, that's a phenomenon that we're aware of. So certainly we can understand why in many of these places there's a big upsurge in type 2 diabetes. But I'm going to be talking to you about something different. Now, I want to give you a couple of examples of places where type 5 diabetes is really showing up, one of them being sub-Saharan Africa, here in red. And you'll see that you might not get as excited about the numbers that there are right now there compared to other continents, but what you'll see is that it's predicted that sub-Saharan Africa over the next 25 years will see the greatest rise in overall prevalence of diabetes, all types of diabetes mellitus will be increasing dramatically unless we do something about it now. Another big area, of course, would be what says here, Southeast Asia. I'm most familiar with South Asia, which you'll see here in purple, the Indian subcontinent, where we're seeing a massive amount of diabetes and a large projected increase over that time period. So these are very important areas in the world to be looking. A lot of it, again, is type 2 for different reasons than we tend to get it here. They tend to still be more slender, younger, and yet that early life programming sets them up. But they're also prone to another type of diabetes. And that's what we're going to talk about today, type 5. There we go. So now, brief history of type 5 diabetes. So again, the iconic Herbert Hoppincong. I was the first person I ever heard about this from, because this was first described in Jamaica in 1955. A very astute British physician, Dr. Hugh Jones, noticed that in the academic clinic in the University of West Indies, he had some patients who failed to meet the criteria for either type 1 or type 2. In other words, they were young and thin, but they didn't require insulin for survival. They weren't going into ketoacidosis. On the other hand, they were thin, so they didn't meet the criteria of type 2, and even went to the point of actually doing liver biopsies and showed that these individuals had no fat in their liver. in complete distinction with type 2 diabetes. So this was remarkable enough that it got published in the Lancet 70 years ago. And because of the impact of Lancet globally, this paper was read around the world. And so what was initially thought to be a Jamaican form of diabetes quickly was noted to be occurring in many other parts of the world. I'll show you a map, but basically all around the tropical or low and middle income countries in the world, reports very quickly started popping up because people realized that they were seeing this same entity in so many places. And I'm going to go through with you the exact classification so you can recognize what they were describing. But enough of this was occurring, enough reports were coming out that by 1985, this actually got a classification by the World Health Organization. The classification was malnutrition-related diabetes. And this is Professor J.S. Bajaj on the left, now deceased, was a great proponent of this. He was the head of the IDF, but also had connections with the World Diabetes Organization at the WHO at that moment. And so he was really instrumental in helping to bring about this classification. Unfortunately, the classification was completely removed in 1999, and it has not reappeared in subsequent WHO classifications of diabetes. The reason for removing it was that there was a lack of convincing evidence of a causal association of malnutrition with diabetes. And in their view, if you couldn't prove that malnutrition caused diabetes, then there was no reason to give it that name. However, I would like to point out the subtlety here that its name was actually malnutrition-related diabetes. That does not inherently imply a causality. And in a recent paper in Physiology, we actually did an extensive literature review, both of animal and human studies. And certainly, in my own opinion, there is a lot of evidence to suggest that undernutrition contributes to the metabolic defects that are canonical, shall we say, for this form of diabetes. So be that as it may, as of 1999, this condition completely lost a classification. Nonetheless, notwithstanding the lack of its name, reports continue to come out from around the world, places, so South Asia, Uganda, Ethiopia, Rwanda, Korea, and many others, kept putting out reports saying that they were encountering what had previously been called malnutrition-related diabetes, started coming out under different names. So Charlotte Bavuma from Rwanda did an extensive systematic review back in 2019 and searched under an incredible number of names because it was popping up under all sorts of names. Some people simply called it type 1. They didn't have the ability to prove that it was type 1, but just simply because they were young and lean, etc. There were other people calling it atypical low BMI diabetes or non-ketosis prone diabetes. There was a whole variety of different names, but what was clear was it was still occurring. And the problem, though, was for those of us that wanted to carefully study this condition, it was very difficult to look for funding and to publish data about a condition that didn't have a name. And so it was our goal not just to do the kind of work that would establish it clearly, but to be able to then advocate for its classification again. And what we did, our own group did, over the course of about 10 years, we partnered, and I'll show you, with a medical school in India. We generated data from very in-depth physiology studies that we believed, and I'll show you subsequently, we believe made this condition unique from other forms of diabetes. And similar reports started continuing to come up from other parts of the world, including Uganda. I'm going to show you all of that. So when it had a name, when the WHO called it malnutrition-related diabetes, what were they referring to? Well, they were referring to exactly what Hugh Jones described back in Jamaica in 1955. They were describing people who tended to develop their diabetes fairly early, fairly young, but they were universally very thin. And we realized that this cutoff point of 18.5 is actually an important one. As we look at our own data and other people's data, it seems that that's a very, for whatever reason, physiologically very important, because below that level, these people are very thin. They don't have fat stores, and their physiology is very different from lean type 2 diabetes. Now, what else was reported about them? These individuals tended to have a history of poor nutrition that began in utero, but that could also be the Barker hypothesis. But these individuals didn't ever catch up. They remained undernourished in infancy. They remained undernourished through childhood and into adulthood, which is when we were studying them. And so they never caught up. They were stunted in terms of their height. They were reduced in terms of their lean body mass. They had negligible fat stores, and yet they had diabetes, which was a non-autoimmune, non-ketogenic form of diabetes. What we do know is that when they presented to these rural clinics, and if someone suspected diabetes, if they didn't just go on to die of, quote, malaria, if someone suspected diabetes and measured their glucose levels, they were found to be really quite severe in terms of the degree of hyperglycemia. And therefore, when they were being treated, usually in these rural clinics, it was believed that they would require a lot of insulin. It seemed to make sense. Their glucose levels were so high, they were placed on a lot of insulin. So the general word on the street was that they were insulin resistant. But that was really just based on a clinical decision based upon their high glucose levels when they presented. Now, the other key point is that pretty much universally, it's been found that they're not prone to developing ketoacidosis. As we delve further into this, I think you'll see why they probably don't. But I want to go back to the second last point, because the reason why we wanted to do these extensive studies was that these individuals that we were encountering, I first encountered them on the diabetes ward in a big hospital in Uganda, Mulago Hospital in Kampala, seeing a big diabetes ward. Some definitely had type 1. You could tell at the foot of the bed. They had the Kussmaul breathing. They were gasping for breath. You could smell that fruity smell of the ketones. You could see their clouded mentation. There was the classic presentation of type 1. And then there were the ones that didn't have that presentation. This is because we don't want to use the photograph, this is an artistic rendition of an individual that we met actually we met him in a village. He had had symptoms of polyuria polydipsia for about 2 years, was getting dehydrated. He was quite emaciated, constantly thirsty, but had survived for over 2 years without any insulin. Did not present in ketoacidosis, just presented hyperglycemic and dehydrated. We got him to the main medical school hospital, believing at that point, because we didn't know otherwise, we believed it was type 1, as did the doctors there. We were able, which was unusual there, but we were able to get him insulin and test strips, supplies. We were able to teach him about administering insulin and recording his blood sugars and all sorts of things, did a lot of education, sent him back to his village with a follow-up plan that he would come frequently into the city for his follow-up care. Someone went to see him, and he was doing well, they said. He looked well, and then he didn't wake up the next morning. And I presume that this boy, like many of the young people that we've encountered, died of hypoglycemia because the amount of insulin that seemed appropriate when he was being fed meals at this big hospital was no longer appropriate when he got back to his village. Sometimes the food was abundant when it was harvest, and other times before the next harvest, it was very minuscule. And so, like many of these other people, he died presumably of hypoglycemia because of the amount of insulin he was on. So that brings me back to that second last point. I was thinking, if these individuals really are insulin resistant, we could potentially save a lot of lives, because maybe they could just be managed with oral insulin sensitizers. Maybe they don't need insulin at all. And so this is what propelled us to get involved in a very ambitious research project. And why did we care? We cared because this was such a prevalent condition. Again, even if the name got taken away, even if all we could call it was undernutrition associated diabetes, there's no question that it's been reported in so many countries around the world. You can just look at sub-Saharan Africa, look at Southeast Asia, even a couple of countries in South America. And we believe that it's probably underreported in a lot of other areas that are experiencing a lot of undernutrition, like Haiti, for example. And so we came to believe that the prevalence of this condition was probably about 20 to 25 million. When we took into account how many people in low and middle income countries had diabetes and how many likely had this undernutrition associated form, aided and abetted by the fact that the global prevalence based on recent data of undernutrition is about 1 billion. So despite what anyone might say, the problem of undernutrition is not going away. We are in the face of a global food crisis. We can think of many places in the world where that's the case. Right now, it's not getting better anytime soon. And so just be sure that there's an incredible overlap between where these cases of malnutrition-related diabetes were being reported and where undernutrition still remains an incredibly important problem. So this motivated us to want to study further this condition. The first question really was, how in the world could you get diabetes when people were so thin and they didn't have an autoimmune type of diabetes? So the first thought that we had was, well, maybe it's a functional form of lipodystrophy. Maybe because these people don't form proper adipose tissue depots, and again, adipose tissue had been one of my areas of interest. If they lacked normal adipose tissue, then surely any fat that came in their diet might go directly to tissues, particularly liver, where the triglyceride could accumulate and give rise to insulin resistance. Was this why in these rural clinics they seem to require so much insulin? Or was it in early life, because of the fact that they had both protein and total calorie malnutrition, was it because the development of the beta cell is, those critical time points are in utero in the first 2 years of life. If someone is lacking protein, calories, and micronutrients, that would be very deleterious to the development of beta cells. So could that be then leading to a lifelong problem of poor insulin secretion? So which of these two might this be? Obviously, the first one would be easier to treat, but we would have to be incredibly vigilant to see whether, in fact, there was a defect in insulin secretion, because if so, that would lead us to a very different pathway of treatment approaches. So our goals then were to define the metabolic phenotype of low BMI individuals who met the characteristics that were previously described as malnutrition-related diabetes. Again, we had to very carefully dance around that name because there no longer was a name. But basically, we were looking for the people that previously would have been called by that name, but we wanted to use gold standard techniques. We wanted there to be no debate about this with the question, well, there's not enough research. Well, we wanted to be sure that there was research of such caliber that there could be no argument about our findings and our description of these people. So we undertook what's called stepped insulin pancreatic clamps. I'm going to show you, I'm going to walk you through them. C-peptide deconvolution study, so we gave them a mixed meal test. We did all sorts of mathematical modeling, I'm going to show you that too, to generate curves for insulin secretion. And we did sophisticated anthropometric measures. We put them into 3 Tesla MRI machines. We were able to look at all sorts of fat depots and look at that very carefully. But I'd like to emphasize one point very critically, because one of the things we did before we studied anybody was we were taking them in a very hyperglycemic condition, just as I mentioned. So we had to address that question. Why were they requiring so much insulin in the rural clinics? Was it simply because they were so glucose toxic? And I'll use that word if knowing that we have a mixed internal medicine audience, the term glucose toxicity refers to the toxic effects of hyperglycemia. So long-term hyperglycemia has a negative effect both on the beta cell, so there's poor insulin secretion, but also on insulin action. So people become more insulin resistant just simply because of the glucose toxicity. We knew that to get to the bottom of why these people had diabetes and why they were requiring all that insulin in the rural clinics, we had to first correct carefully that glucose toxicity. We had to bring them down to normal glucose levels. We did that very intensively, and I'll get into that in a minute. So where in the world, literally, could we do this? We located the one place that was actively conducting insulin clamp studies because of a collaboration they had with the University of Copenhagen. So This was a top-tiered medical school, tertiary care center, founded by a woman physician from New York, Ida Scudder, back in 1900. So I would sort of walk in her footsteps, as it were. And I was able to invoke the name of Aunt Ida on many occasions whenever I needed something to get done. So that was very convenient. But this is an enormous place. It now has 3 campuses. It's got people coming and going from all around the world. And they also have a lot of research. So why we partnered with a group there. Again, you can see the 3 Tesla MRI. You can also see that they already had the infrastructure for doing these metabolic clamp studies that I'll describe to you. To my knowledge, this is the only institution in a low and middle income country that actually has this capability. And I'll show you. You'll see, I think, in a minute why that's a big deal. Again, they've been doing a simpler version of this with the University of Copenhagen, so at least they already had a sense of what they needed to do. But we realized that to get to the bottom of this very perplexing condition, we were going to have to do far more complicated studies. And so we had to first exclude type 1 rigorously. So we had to exclude any history of ketoacidosis. We had to exclude seropositivity. We did these 2 particular antibodies. Of course, if they've had diabetes for a while, that can't be completely definitive, but they even looked at HLA types. They ruled out ketoacidosis, etc. We really wanted to be as clear as we could be that we weren't looking at type 1. And then we had to rule out pancreatic forms of diabetes, so looking at history, presentation, abdominal pain, etc. We did imaging to be absolutely sure, because there's another form that can occur with malnutrition in these settings, fibrocalculous pancreatic diabetes. It's exactly as it sounds. If you were even just to do a plain film of the abdomen, you might see these areas of fibrosis and calcification. But certainly doing it with ultrasound, or in our case, we did it with CAT scans, we were able to rule out that as being one of the etiologies. And then we wanted to make sure that this simply wasn't just everyday type 2 diabetes in somebody that had just lost a lot of weight and had got their BMI less than 18.5. So we ruled that out. We also ruled out all known monogenic forms of diabetes. Our colleagues were actually very good at doing this. They did genotyping. They ruled out every known form of MODY as well as lipodystrophy. So we had to screen about 150 patients in order to find the 20 that I'll show you that we studied so intensively. And we had to also, to find them, had to go right out into rural areas. My team went frequently, not only to supervise and train regarding the clamps, but also literally to go out into the rural areas, 3 hours north into a further north state where the nutrition was poor. And they would be going into these rural clinics, going through hundreds of charts in order to find the patients that met these criteria. We knew that a lot of them were out there in these impoverished settings, but finding them around a world-class tertiary medical care center wasn't easy. So it was a question of getting out there, finding them, bringing them in, and studying them intensively. And so the group in orange is the group where, after exhaustive exclusions, we managed to find a group of people who were impoverished, undernourished, stunted, had had a lifelong history of undernourished, low birth weight. They'd already had diabetes for at least 10 years, so they would have presumably been in their 20s mostly when they were diagnosed. They had low BMIs. We were aiming for less than 18.5. Most of them were, or just a little above. So they were very lean. They also had very poor glycemic control when we recruited them, but that was at the time they walked in the door. How do we bring them down? I mentioned that we had to control them very tightly to bring them down and correct that glucose toxicity. So they came and lived near the medical center for about 2 or 3 weeks in nearby hostels. Members of the diabetes team treated them very intensively, brought their sugars down, and then overnight before the study, they had an insulin infusion, so that by the time of the study, all of these groups, these diabetes groups, all started out with a normal blood sugar in the morning. Because we needed to know whether this was really just type 1 or type 2, we of course had to have groups of people with known classic type 2 diabetes and classic type 1 diabetes, definitively diagnosed, absolutely certainly classic type 2 and type 1. Then we had to have non-diabetic controls. But because we had type 2s and low BMI people, we had to have 2 groups of controls that were BMI matched, one to the low BMI group, the lean non-diabetics, and then one group that were more leaning towards overweight, who were matched to the type 2s. So we studied all of these groups extremely intensively. This whole project took 10 years. Now, this was the type of clamp study that we did. This is quite unique. This is, to my knowledge, the only place where this has ever been done. And that caused me to wake up many times in the middle of the night thinking, what in the world are we doing? These incredibly complicated studies at the other end of the world. It's like it was wild. I would have to say, to teach all of these techniques, to supervise, train, make sure that these were being done correctly, to get the blood samples all sent back, in many cases to be run in our institution, because we were using things like stable isotopes of glucose that had to be measured under very sophisticated techniques. This is why this has never been done in a low and middle income country before, and maybe never will again. But 10 years later, thank God we had a publication. So first of all, I'll explain to you why we call it a pancreatic clamp. We wanted to have such tight control over the insulin in these studies that we had to remove endogenous insulin secretion completely from the picture. So how do we do that? We gave somatostatin that would inhibit insulin secretion, but it would also, of course, inhibit growth hormone and glucagon. So we gave back growth hormone and glucagon at basal levels to keep these people under fasting conditions for 6 hours. At the bottom here, you'll see that we had 3 insulin phases. We had the initial basal phase, and we very carefully selected the insulin levels for that basal phase, individualized them for each person. This is why I say that this is rather unique, because we wanted to be so sure that we were dealing with a very different population from what we studied in New York. And so we wanted to be sure that we could personalize the insulin that we were giving to their own insulin requirements. So once we'd done that over the first 2 hours, kept adjusting and adjusting the insulin till we found what was right for them, we then put them through the low insulin phase of the study. So we gave a small increment in insulin so that we could optimally study the liver. Because if we gave the liver too much insulin, it would completely shut down and we couldn't see any difference between the groups. So we had to study them at a low insulin level, where if they were insulin sensitive, they would be reduced more than if they were insulin resistant. So there was the liver phase of the study, the low insulin phase, and then there was the high insulin phase. So we took them up a big step to maximally stimulate glucose uptake through their whole body. That would be mostly skeletal muscle. And so that would then give us a whole body measure of insulin sensitivity. I mentioned that through the whole study, we infused a stable isotope of glucose, which we ourselves measured. And the reason for that was that we could measure the glucose, literally measure how much glucose was taken up minute by minute by the different tissues, and also measure by subtraction how much glucose was being produced by the liver. And then during the phase where we were giving more insulin, we had to infuse variable amounts of dextrose because we had to keep them euglycemic. And hats off to the team at CMC. Yes, there was a lot of supervision. Yes, my team also worked very hard. But I would have to say that they did a spectacular job at maintaining pristine glucose levels throughout those whole 6 hours. It really was amazing. And then when we looked at the measures of the tracer as well, I was astounded to see how stable those dynamics were. So now the results. I'm going to start with looking at hepatic insulin action, and that's measured by endogenous, which is mostly liver, glucose production. We're going to start with the normal group. This is the lean non-diabetic group in green. You'll see that even under low insulin levels, there's quite a bit of suppression. So if you picture that things were, if you can see my red cursor up here, if you can picture that being fasting glucose production up here, you'll see that the low amount of insulin that they got suppressed them quite a bit. And some of them down to 0. Some of them completely shut off their glucose production. Overweight people trending toward a little less suppression. But look at type 2 diabetes. Again, we see sort of fasting being up here. The ones with type 2 diabetes had much less suppression in response to insulin. So we can say they were insulin resistant at the level of their liver. Very classic, what we would have expected. Type 1 diabetes, here in the pink squares, you'll see they were heterogeneous, but you'll see on average, they were, if compare them to the normals, again in green, compared to the normals in green, you will see that they were trending towards insulin resistance. Not surprisingly, there was recently a review in Endocrine Reviews going into the topic of type 1 diabetes and insulin resistance. So this would be consistent with literature. There was heterogeneity there. But big question, what about the low BMI diabetes group? There they are in blue. Where do they fall? Compare them to the normal in green, and you'll see that they were not different. Even though there was some heterogeneity and there was one outlier who was insulin resistant, nonetheless, as a group, they were remarkably insulin sensitive at the level of their liver. Well, what about the rest of the body? What about whole body? So this is whole body glucose uptake, and the higher it is under the influence of high insulin, the higher the glucose uptake means the more insulin sensitive they are. So you'll see the control group in green. You'll see the amount of increase in glucose uptake that was observed with high insulin, little trend lower in the overweight control group. But look at the type 2s in the black triangles. They have only about 40% of the glucose uptake that we saw in the lean normals. Not surprisingly, the type 2 group was insulin resistant, not just in the liver, but the whole body. Here is the type 1 group, maybe a little trend toward insulin resistance when we look at the normal controls. What about our lean diabetes group, low BMI group? In blue, there is some heterogeneity, but on average, they line up. There's no difference between the low BMI diabetes group and the lean controls. These individuals, on average, were remarkably insulin sensitive. So that was quite a surprise, suggesting, going back to that rural clinic where they were getting so much insulin, suggesting that that was because they came in very glucose toxic. And once we'd corrected all of that, they were remarkably insulin sensitive. Now, what about, where is the problem then? How do they have diabetes if they're so insulin sensitive? Well, we next looked at insulin secretion. This was a mixed meal tolerance test, and it went on for 3 hours. We measured C-peptide, we did mathematical modeling. What was normal? Look at the green. You'll see very nice first phase insulin secretion, right up to the peak, 1 hour. Then a very nice decline very quickly down to normal. So that's normal, and we know it's normal. The overweight controls had even a slightly heightened, trending towards a heightened amount of insulin secretion in response to that meal. But let's look at type 2 diabetes in the black. Not surprisingly, consistent with the literature, complete loss of that first phase insulin secretion. So they didn't get up to a peak. They got up to a plateau, much less than the normal peak. And they stayed at that plateau. They didn't come back down again. So they would have, whatever insulin levels they attained, they would have kept circulating, which could have its own issues. Now, at the very bottom, you'll see type 1. Not surprisingly, they did not have any response in terms of insulin secretion in response to that mixed meal. But what about the blue group? What about the low BMI diabetes group? We were astounded. After we corrected the glucose toxicity, we were astounded at what a severe defect they had in insulin secretion. You can see it's much more severe than the group with type 2. It is not, however, as severe as type 1. So think about the fact that they don't go into ketoacidosis. Think about the fact that they have enough. They don't respond well to a meal, but they have enough insulin secretion, presumably, that they've got a robust enough amount of malonyl-CoA in their liver that they can inhibit ketone production. So that probably explains why they're not prone to ketoacidosis. There may be extreme situations, and again, this requires more study, but the classic presentation is no ketoacidosis. So the next question is then, as mentioned, we put them into the magnets, we looked at their fat depots everywhere, and well, let's look at that. Because, yes, they could be very lean, but maybe they're putting their fat in their abdomen. That was the first question I had. So let's look at that. Let's look at visceral adipose tissue. This is the green, the control group, non-diabetic, lean people, pretty much no visceral fat. The overweight control people did have visceral fat, as did the people with type 2 diabetes. They had a considerable amount of visceral fat. But the type 1s did not. The low BMI diabetes, again, a little heterogeneity, but did not significantly differ from the lean control group. So they were thin everywhere. Now, key question, of course, we're so interested now in intrahepatic fat, such a big deal, MASH, etc. Again, is it possible that because they don't have adipose tissue, any lipid would make its way to the liver? and affect their metabolism. Well, let's look into that. So first of all, in the green, this is the normal control group, very low intrahepatic lipid as we would expect. And even here, the overweight group didn't have much. The type 2 group, there's a spread here. Some of them didn't have much, but overall, they had considerably more visceral fat compared to the lean controls. Type 1, virtually none. What about our low BMI diabetes? Of course, it would happen this way. The dot at the top is the very first participant we studied. And this individual did have intrahepatic lipid, thinking, okay, this is it. We're on to something. These people really do have fat in their liver, but what do you know? Most of them had absolutely no fat at all in their liver. So a very different phenotype from type 2 diabetes. So therefore, let's go back. Why do these people get diabetes? Is it because they're insulin resistant? No, they are not. Once you correct the glucose toxicity, they're insulin sensitive, both in their liver as well as in the whole body. They don't, other than one person, they do not put triglyceride in their liver. So where's the problem? They have a very significant defect in insulin secretion. Now, was this unique to India? No, it is not. So this is a study that came out very soon after, a Ugandan study. They first published a paper in Diabetologia with 160 patients that had BMIs under 25. So we were interested and asked them, could you please do an analysis of the ones that had BMIs of under 18.5? So here you'll see everybody, all 160 that were under 25, and then you'll see, blown up here a bit, the ones under 18.5, not a large group, but what you'll notice, much less body fat if you go across the line, much less visceral fat, higher hemoglobin A1Cs, very similar to what we saw, higher fasting blood glucose, much higher, a much lower fasting C-peptide, and much lower stimulated C-peptide. And so leading us to say that in this context, in the Ugandan experience, low BMI diabetes was associated with very low body fat and poor baseline and stimulated beta cell secretion. And so very similar to what we saw. And soon thereafter, another study came out of India. Looking at a lot of people with quote, type 2 diabetes. Well, they didn't have type 1, they weren't autoimmune. And they stratified them by BMI. Let's start at the right. These people were markedly obese to mildly to moderately obese to overweight to normal weight, normal being anywhere between 18.5 and 23, basically. Now, we're looking down at the lower parts of the table here. Fasting plasma glucose. Let's go from right to left. And let's see, it's bebopping along in the 170s up to the 180s. Suddenly you get to a BMI of under 18.5, you jump up to 221. Postprandial glucose bebopping in the 200s, high 200s, over 300. A1C bebopping in the 8s, the low 9s, all of a sudden 10.3. Same thing here. We don't have clamp studies being done, but we do have triglycerides as a rough measure of insulin resistance. And yes, the higher BMI people definitely have higher triglycerides. All of a sudden, BMI less than 18.5, normal triglycerides, suggesting normal insulin sensitivity. And then we've got down to fasting. The last two rows are fasting and stimulated C-peptide. Let's look at the obese people. They really stimulate their C-peptide. Looks great. Looks great all the way over normal weight. Looks a little less great, but all of a sudden, big drop. When you get less than, this is over 5,000 people. You get less than 18.5, all of a sudden, marked drop in both fasting and stimulated C-peptide. Very similar to what we found. So given that there were people all around the world bringing up similar findings, not always doing these clamps and so on, but the bottom line was when we published that paper 3 years ago with our findings, we started being contacted by the people around the world that were doing work on similar individuals and coming up with similar findings, even if the measurements they were using weren't as complex. So we said, let's come together in person. Just as it's great to have you guys in person, there's nothing like actually being together in the same room. We've got to get these people from all around the world coming together for 2 days for a consensus meeting. They present their data, but who do they present it to? Just to each other? we brought in world leaders in epidemiology, in insulin secretion, and also we brought in the heads of various organizations. So we brought in the president of the International Diabetes Federation, the editor-in-chief of Lancet Global Health, the head of the American Diabetes Association, and the head of diabetes for the NIH. They were all invited to be present and critically review all of these talks, talk after talk, the big discussion time, critically reviewed all of the data that was being presented, and all of them presenting this type of diabetes with low BMI and undernutrition. 42 people. I don't know if everybody was internationally acclaimed, but a good number of them were. But the bottom line was, what was most important was we had a lot of people who had worked for decades on the ground in these places doing this work. And the idea was to discuss the phenotype of this type of diabetes. At the end of the meeting, we convened a discussion and a vote. And the question was, do you believe that this form of diabetes is unique, at least distinct from type 1 and type 2? So there was a unanimous vote among every member present that it should be distinct, that it was distinct, it was non-autoimmune, it was not associated with insulin resistance, it was severe insulin secretion, no body fat, etc. Then, so I'll show you a couple of pictures. These were the participants of our meeting, very global distribution. And this is Peter Schwartz, the president of the International Diabetes Federation. This is showing the moment at which Peter Schwartz stood up and said, I declare that this should be called type 5 diabetes. So why type 5? Well, we know about type 1 and 2. You all may know that type 3 has been claimed by Alzheimer's associated diabetes, also pancreatic diabetes. The American Diabetes Association calls type 3C pancreatic diabetes. Type 4 has been claimed both as aging associated, and what will come on the horizon soon, brewing, is that there'll be a proposition for gestational diabetes to be called type 4. Therefore, we needed to have our own lane. So Peter said, make sure there's no arguments. Don't get to be 3D. I mean, make this straightforward. This is clearly an important entity. It's affecting millions of people in low and middle income countries. And of course, most cases of diabetes are in low and middle income countries. Therefore, he said, it should be called type 5 because this will make it unique. It'll be catchy. People will pay attention. It'll be different. And you'll never be competing with another group for this name. It also gets you away from that whole, quote, malnutrition question that had plagued the former designation. So, true to his word, at the World Diabetes Congress in Bangkok, April 7th of this year, he got up and proclaimed type 5 diabetes, and the very next day, he inaugurated the type 5 diabetes working group, which I now chair, not voluntarily, but because managing people across the world and trying to keep things on track is not an easy proposition, but I am passionate about this area and therefore want with all my heart for this to go forward. We published a consensus statement that came out of that meeting. And in that statement, that paper has just come out just this month in Lancet Global Health. And I want to point out that this is something that we needed to try to clarify, and we still need to clarify, because in high-income countries, you can have mishaps, as we know, intrauterine mishaps. In low-income countries, you can have intrauterine undernutrition, but all of that can lead to issues in utero that if you catch up later and get properly nourished, sorry, this is the upper part, if you subsequently get overnutrition or even adequate nutrition, but if you were programmed for low nutrition in utero, you can then go up to classic type 2 diabetes, as we know so well, and associated with all the things it is. These people starting out undernourished or starting out low birth weight can have a propensity to more obesity later on, more insulin resistance, etc. We know well that trajectory. We know it very well. But what is unique about this, as I mentioned before, is that it starts out also undernourished in utero, etc., but they don't catch up. They have, what you'll see here, persistent life course undernutrition. Infancy and childhood, We know that this period here being critical for beta cell development, then through childhood, adolescence, adulthood, they're still undernourished. When they present with a non-autoimmune form of diabetes, this is what we're referring to as type 5 diabetes. So this is going to need a lot of clarification, but this is yet another reason to say this is absolutely distinct from what we think of as type 2. So 5 action points for type 5, global registry for global research collaborations, more research on pathophysiology, and management is going to be critical. Define diagnostic criteria. They'll have to be very grassroots oriented, very clinically oriented, in order to be able to diagnose this in places where you can't do fancy laboratory tests or imaging. And we've been invited to present our guidelines. No pressure in less than 2 years. Anyway, I will present something. Hopefully it'll be in advance over what we know now. And eventually we want to be able to give enough information. There will be a textbook chapter in the next DeGroote's endocrinology about diabetes in low and middle income countries. I've been invited to do this, and it will, I can guarantee you, include type 5 as well as other forms in these settings. But the bottom line, and this is where we're ending, the bottom line is, why do we care? Why do we want to distinguish type 5 from types 1 and 2? What are the implications? Number one, when these individuals come to my clinic because they're seeking asylum, they've arrived in a high-income country, and I gather that's very much the case here in Montreal as well, that they could be treated by our fellows who might put them on GLP-1 agonists. Doesn't everybody want to put people on GLP-1 agonists? The bottom line is we don't want these people losing weight. We don't want them losing lean muscle mass. Number two, metformin. I know that a lot of people are using it empirically in these individuals, and it's probably safe. Of course, it's not addressing the insulin secretion issue, but it may be helping generally to lower glucose production, etc., and may help in the overall picture. But we have to be extremely careful to not precipitate hypoglycemia, not give them too much insulin. We have to be very wary in using sulfonylureas, etc. It can be very dangerous in the face of food insecurity, as I've seen so often. And insulin use in general is problematic in many low and middle income countries, but given that degree of insulin secretion defect, they probably will require at least a small amount of insulin. Protein, yes, if we were to think about what they should eat, probably a high protein diet, something that would be less immediately, less likely to turn into glucose, more able, the amino acids, micronutrients being important for beta cell function. But the bottom line is more research is urgently needed because developing appropriate treatment strategies is critical. And I want to thank many people that were involved at various steps, all the way from people coming over to India, the various people that worked on my team were also here, and then the large number of people at CMC Valour, my own funding, which helped us to do this, and a very, very generous anonymous donor. So thank you. I'm very glad to be here. I'm going to stop share for a minute. I could always return to the slides if there's any questions pertinent to them.
That was great. Thanks, Meredith, for taking us through this new area and so nicely showing the pathophysiology. We're looking forward to learning more about it. So the floor is open for questions here in the room or on Zoom. Simon.
Thank you for that lovely presentation. Congratulations to you and your colleagues everywhere who persisted in getting this very excellent study done.
And people on Zoom here, no, there's a microphone there.
Oh, yeah. So I guess my main question is, you very clearly showed that it's a defect in insulin secretion. So I'm curious, is it a defect in respect to glucose-stimulated insulin secretion, amino acid-stimulated insulin secretion? Because that could have implications to your dietary management.
Excellent question. And because we used a mixed meal stimulation test, we can't distinguish that. So they were stimulated with glucose, amino acids, and fats, and that combination failed to result in a robust stimulation of insulin secretion. What I will say is that my colleagues have now been looking into incretins, and they believe, or their early data suggests, that there may be a marked defect in insulin, in incretin secretion, and that may be part of the issue, in addition to the issue with the beta cells. Thank you. And so we have one online, and then yes, and one live.
If every pregnant woman in the world got a sufficient food subsidy, would this disease disappear?
So that's a great question. If we were able to target this in women of childbearing age, it has been noted that in states in India where they have improved dramatically their nutrition, they fail to, after a generation or two, they fail to see this anymore. So yes, if we were able to figure out a way, particularly for that very susceptible group, then yes, we could make it go away. Dr. Muriel, I see you online with your hand up.
Hi.
You're muted.
Are you muted?
Uh,
Let's see, can we unmute you? Let's see if we can do anything here.
Jose, can you unmute yourself? Oh, he
You
isn't.
guys hear me? I am unmuted from
Yes,
here.
we can.
Okay.
No, we can.
I was
Great.
just silent.
Mhm.
Very impressed by the presentation. And let me tell you, only those who have done somatostatin clamps understand the amount of work that goes on with it. And things gets even more complicated if you try to use labeled glucose to understand endogenous glucose production on top of your glucose uptake in the periphery. I have a question, which is, have you defined the lean body mass of these low weight diabetics or type 5 diabetics persons, which I would expect to be low, but the proportion of it over that of adipose tissue, compare this proportion with other groups of diabetic subjects and lean controls in order to understand if they suffer from further loss of lean tissue, associated with their condition, because there is normal range of what should be lean versus fat tissue. But have you tried to characterize them further in terms of their lean body mass?
Yes, so the lean body mass is definitely also decreased, but you're asking a great question, and we didn't specifically look at the ratios. The fat mass was definitely markedly reduced. If I had to make a wild guess, I would say that they were proportionally lower in fat because some of them had virtually no fat at all. But they all definitely did have a decrease in lean body mass as well. And we had to correct when we presented, what I didn't tell you, but when we presented the whole body glucose uptake, we had to correct that for lean body mass because it differed in all the different groups.
And was it lower than the other groups, which will signify some degree of peripheral resistance as well, but wasn't the case, right?
Right. No, in other words, at the end of the day, when we corrected everybody, when we basically measured and corrected everybody for lean body mass, they remained, the differences that I showed you remained, so that our individuals remained insulin sensitive, and the type 2s were very insulin resistant.
You answered my question. Thank you very much.
Well, thank you. My pleasure. Now we have 3 or more online, 3 in the chat, and then we've got 2 live. So should we go live chat, chat? Okay.
Very.
Thanks for a great presentation. So now I have questions as opposed to last night when we had the pleasure of dinner. So I would make a pitch for more descriptive naming of diabetes types. Like I've often thought type 1 should be called immune diabetes, and this sounds like underweight insulin deficient diabetes.
Yes.
I think it would be better for patients and for practitioners.
Yes.
So maybe you could take that to the committee would be my first step.
Yes. Yes, because one of my involvements has been the NIH has been very interested recently in the heterogeneity of diabetes, and it really is so heterogeneous. And so I think, thankfully, and type 2 is just such a grab bag. There's really no clear definition of what it is at all. So I completely agree. And then we've got these various clusters and all these other things that are showing that even among what we think of as type 2, there's just so much heterogeneity. So right on, the more descriptive the names can be to what people actually have, the better it would be. I agree. Now, should we alternate chats and then, okay.
Sure. That's what I can check.
So we have a comment on the challenges of ethics approval and obtaining informed consent. So that was something that we did at both ends. We did that at my own institution. We did that. Christian Medical College Valour is an incredible institution. They have a lot of global collaboration. So they had a very, what should I say, rigorous IRB process that we went through in terms of submitting, reviewing the protocol, and then in ensuring that we were doing the informed consent process appropriately there. So everything had to be translated into Tamil, which was the local language, and we had to go through, as we would anywhere, we had to go through a very careful process of making sure that everything was explained and everything was understood very clearly. Should we go to, okay, well, sorry, one more. Is type 5 diabetes a risk factor for early onset cardiovascular disease and kidney disease? Because in India, they occur in earlier decades than Western populations. Most likely true. We haven't been able to follow them long enough to look at the cardiovascular, but intriguingly, classically, their issue is neuropathy, more so than any other they get all complications and they die young. But neuropathy seems to be their particularly unique. They're more prone to neuropathy relative to other people with diabetes, and I wonder whether that's because of the vitamin deficiencies on top of the severe hyperglycemia. And then, so my question, I think that was amazing.
Sorry, thanks. When you get to the point that you're treating these individuals, obviously the socioeconomics of their origins, of where they are in the world, depend on if you can successfully treat them. But if you go a little too far, like if they're here, then you might end up just simply getting insulin deficient, insulin resistant diabetes, or a worse kind of diabetes than they started with.
Exactly.
So it's obviously going to be a fine line finding where to treat them to and how best to do it. It's going to be a challenge.
If we were just to fatten them up,
yeah, it's
with
not
with
not
low calorie, with low quality simple carbohydrates, and allow them just to become plump, we would just drive them very quickly into type 2 with a more severe defect in insulin secretion.
That's the kind of stuff
exactly. So we could do much harm. Whereas potentially increasing lean, if we could increase lean body mass, if we give them protein, if we could replace all the micronutrients like zinc that are definitely deficient in these people, if we could optimize insulin secretion by every mechanism that we can, I believe this could be helpful. Another reason for needing this research, we have another question online. Do we know anything about the beta cell mass of these patients? Is this reduced? So we ourselves do not. There's a group in Hyderabad in India, the Beta Cell Institute, that is actually going to have access to cadaveric beta cells and actually be able to look at this, cadaveric pancreas samples, and be able to look at the beta cells and be able to determine. My prediction would be that they're massively reduced if we could actually look at them, but it'd be very helpful to know that, to see that on slides. And the one thing though that I can say is that on imaging, surprisingly, I mentioned there's really no fat in the liver. There's also no fat in the muscle, but a few of them actually have a little bit of it's seemingly lipid in the pancreas. Be that whatever that means. But I think more histologic or gross pathologic and histologic study of the pancreas would be extremely helpful.
Perhaps I could ask one last question. Last night you mentioned about genetics and that not everybody with low BMI develops diabetes.
Correct.
Can you comment on that?
Yes, gladly I would comment on that, because again, that's right, exactly. If this is just simply what I've told you about the low BMI, the beta cells, the other issues, the intrauterine meets chronic undernutrition, if that was it, then every undernourished person would have diabetes, and they don't. At least unless maybe they don't live long enough to see the the full impact of the metabolic defects, but it would be my guess that there's other factors. So there's probably other environmental factors like toxins, et cetera. But what about beta cell susceptibility genes? The small study that we did was not looking at pedigrees and so on. We don't know if this runs in their families. We also don't know if their family members lived long enough to know if they had diabetes. I wouldn't be the least bit surprised that there will prove to be beta cell susceptibility genes that will make some individuals, particularly if that beta cell susceptibility gene had something to do with development of the beta cells, that together with the undernutrition at that critical moment could explain why some of them are really susceptible to this.
That's great. Well, on that note, we've reached past 1 o'clock, so there's clearly been a lot of interest. Thanks so much, Meredith. That was fantastic and educational. We'll have to have you back.
I would love that.
Next chapter.